Welcome to Tony's tutorial, and today we have a new chapter in biomechanics as our topic of discussion, that is a knee complex biomechanics. And of course we have finished the discussion of hip complex biomechanics and we are moving to the next joint, that is the knee complex biomechanics. And here we will be discussing in detail all the peculiarities of knee complex. But in today's video, we are going to discuss about the structure of the knee complex, especially the structure of the femur, distal end of the femur, the proximal end of the the tibia, the peculiarities of both the structures. This is Tony's tutorial and we are going to discuss the knee complex biomechanics today. We are going to discuss the knee complex biomechanics. As I always tell, before going into a chapter, we need to know what is the significance of studying that. And in knee complex, you know that the hip serves as a weight-bearing joint. It is a stable joint also. And if the hip joint is serving as a weight-bearing joint and a complex joint, what is the peculiarity of the knee joint is it is one of the most injured joint in the human body. When it is one of the most injured joint, there might be some peculiarities in the structure and biomechanics that might be resulting in this sort of greater chance of injuries. We are going to discuss about that. And you know about the knee joint, it serves as an interplay, or it serves as a connection between the hip at the top and ankle at the lower limb, at the lower end. Of course, it serves as a function, it serves the function of weight bearing, and of course, it serves the function of mobility. And another feature, one of the other peculiarity is it has a lot of ligaments and a lot of muscles passing through that joint. And this lot of ligaments poses a greater chances or poses a greater threat for greater chances of injuries at the knee joint. That's all about the introduction. Now we are going to straight into the knee complex. The knee complex in turn is made up of two joints. The first one, which is quite known to us, is the TIBIOFEMORAL joint. Okay, first one is the TIBIOFEMORAL joint, right? The second one, it is the patellofemoral joint. Patellofemoral joint. So that as the two joints in the knee complex. Femoral joint is formed between the proximal end of tibia, and distal end of femur. These are all known facts. Okay, distal end of femur, right? That is what makes the tibiofemoral joint. Patellofemoral joint is made up of the posterior surface of patella, and the distal end of femur, okay? These are the two joints that makes the knee complex in total. Of course, these joints are both immersed inside one knee joint capsule, but still functionally both joints have a diverse function or a different function. So we will be seeing in detail about each joint individually because they differ so much in the function. So first we will be focusing on the tibiofemoral joint and later we will be focusing on the patellofemoral joint in depth, right? So let me rub the patellofemoral joint. Of course, the tibiofemoral joint is formed between, as I told, the proximal end of the tibia and the distal end of the femur. Now, when you study any joint, you need to know the type of the joint, right? The type of the joint here is double condyloid joint. You know that condylar joint is one of the type of synovial joint, but double condylar joint is the peculiar type of joint that is seen in the TIBIOFEMORAL joint. So that is a double condylar type of joint. Now, since it's a synovial joint, it has 3 degrees of freedom. Condylar joint, it has 3 degrees of freedom. Okay, which are the degrees of freedom? That is a flexion, extension, you know that, medial rotation, lateral rotation, and abduction, adduction. But this movement like medial rotation, lateral rotation, and abduction, adduction are not that evident or not up to the degree that you see in your hip joint. But we will focus on the degrees of freedom and functions later. Just let us have an introduction. That is the flexion, extension. Which plane flexion, extension is happening? It is in the sagittal plane. So the axis will be coronal axis or x-axis, right? If you have any doubts with the plane, just look back to the video, the link is given below, about the planes and angles. That is a flexion and extension happening in the sagittal plane. Now you have medial rotation and lateral rotation, which is happening in the which plane? All the rotatory movements happens in the transverse plane and vertical axis or y-axis, right? And you have abduction and adduction, right? Abduction and adduction. Which plane does it happen? It happens in the frontal plane and of course in the AP axis. That's all about the peculiarity. This is in the sagittal plane. This is in the transverse plane. This is in the frontal plane, AP axis. Transverse plane, vertical axis. Sagittal plane, coronal axis. Wow, that's all about the general introduction about the TIBIOFEMORAL joint. Now we are going to discuss in detail about the TIBIOFEMORAL joint. So before that, what type of joint it is? It is a double condylar joint. And how many degrees of freedom does it have? It has 3 degrees of freedom, right? Okay. Now the TIBIOFEMORAL joint. Structure of TIBIOFEMORAL joint. Of course, in the structure of TIBIOFEMORAL joint, you have 2 bonds, that is the distal end of the femur and proximal end of the tibia. So let us discuss about the distal end of femur. Distal end of femur. You might know the distal end of femur in depth in your anatomy sessions, but we are not going to focus much on that, but we are going about the biomechanical peculiarities of this joint. Okay, now if you look at the distal end of the femur, okay, this is femur and distal end, you see that it has 2 condyles. This is quite known to all of us, right? Medial condyle, what? Medial condyle and the lateral condyle. So it has 2 condyles, the medial condyle and the lateral condyle. And just before the medial condyle, you have a projection which can be palpated, known as the medial epicondyle. Right here you have the lateral epicondyle, but medial and lateral epicondyle we need not worry, we just need the epicondyles. Okay, so it has biomechanically, if you're speaking, it has medial condyle and lateral condyle, right? The medial and lateral condyles. Okay, so that's the first point. So the the distal end of the femur is made up of a medial condyle and lateral condyle. Now, what are the peculiarities of this condyle? Of course, this condyles will be having some peculiarity that makes the knee joint complex. What are the peculiarities? If you look the knee joint complex like this, right? Like this, okay? Let me hold it like this. When I'm holding the knee complex like this, can you differentiate between the medial condyle and lateral condyle? In literature, we study that medial condyle is larger than the lateral condyle. But of course, it's not much visible. Okay, it is not much visible because the femur is always having an oblique orientation. See this one, this is having an oblique orientation. The femur is not a straight one, it is oriented oblique. We studied about the angle of inclination, the angle, the longitudinal axis of the shaft of the femur, etc. in the hip complex. If you have doubts, just look back to that. Okay, now if you look like this, okay, this is the orientation of the femur. It is obliquely oriented slightly. Okay, but if you are moving it straight, if it is a straight one, okay, we can clearly differentiate between medial and lateral condyles. Okay, we can clearly differentiate between medial and lateral condyles. See here, now this pencil or the scale is not touching the lateral condyle. Okay, why? That is because the medial condyle is larger than the lateral condyle. But it is not much evident when the femur is oriented. And that is what happening in our knee complex. In our knee complex, femur is having a slight inclination, or it is obliquely oriented, so that the medial and lateral condyles are in a straight line, in a horizontal line, and that makes our knee complex. Okay, but if that orientation is not seen, what happens is, what is the evident is the medial condyle will be larger than the lateral condyle. The medial condyle will be larger than the lateral condyle. But that's not evident because of this oblique orientation. So the first point is medial femoral condyle is larger than lateral condyle. Medial condyle, okay, greater than lateral condyle. Okay, all right. Now let us see some more peculiarities of this medial and lateral condyles. Okay. Now, if we look in the transverse plane, okay, we know that there are AP view, transverse view, etc. If you look in the transverse plane like this, okay, this is the femur, this is the lower end of the femur. See what is the peculiarity. This femoral condyles are convex, right? This femoral condyles are convex. You can see that in the lateral view, it is clearly evident. In the anterior view, it is not that much evident, but in the lateral view, this is completely convex. So the important thing is that in lateral view, so not in the transfer, in the lateral view, the femoral condyles are completely convex, right? That's convex. But there is a peculiarity. This is the anterior end. When it is moving from the anterior end like this, it is having a greater convexity, right? The radius of curvature here is greater. But when we move to posterior end, it ends suddenly. That means the radius of curvature over here is smaller than the radius of curvature in this anterior part. Okay, so that are the important points in the, not in the transverse view, this is the lateral view, I'm sorry. In the lateral view, what happens is the condyles are convex. The condyles are convex, right? The condyles are convex, and convexity is less posteriorly. Okay, or more clearly you can tell the radius of curvature is less posteriorly. So that is one of the important feature in the lateral view, right? Now moving on to the anterior view. If you look anteriorly, right? If you look anteriorly, just let us look anteriorly. What can you see? We can see that the femoral condyles are convex, but less convex than the lateral view. This is more convex, but here it is having less convexity. In anterior view, the condyles are having less convexity, right? In the anterior view, the condyles are having less convexity than compared to the lateral view. It is clearly evident. This much only we can see in the anterior view. This much only it is evident in the anterior view in both the condyles. So that is less convex in the anterior view, right? What about the inferior aspect? If you are looking posteriorly, you can see that both the condyles are clearly visible, right? The most visible aspect is seen in the posterior location. See, you can clearly demarcate the larger medial condyle and less large or smaller lateral condyle. So in the posterior view, the condyles are very clearly visible. So that are the peculiarities of the condyles. You have two condyles, medial and lateral. Medial condyle is larger than the lateral condyle. Both the condyles are having convexity in the lateral view, but the convexity is decreasing to the posterior aspect, or the radius of curvature at the posterior aspect is lesser than that in the anterior part on the lateral view. Whereas in the anterior view, the condyles are convex, but it is not as convex as in the lateral view. In posterior view, you can see clearly demarcate both the condyles. You can see the larger femoral medial condyle and larger or smaller lateral condyle of the femur, right? In the inferior view, this is the inferior view. You can see that, as I told you earlier, the medial femoral condyle is projecting downwards. The medial femoral condyle is projecting downwards in the inferior view. See this one? See? If I am drawing like this, this is a scale. it comes like this. So the medial femoral condyle projects downwards in the inferior view. So these are some of the peculiarities of the medial and lateral femoral condyles. And there is one more peculiarity in the anterior view, that is, you can clearly see that. See, if I am drawing a line, a scale from here to here, it will get obstructed over here. That is, the lateral femoral condyle is having slight anterior projection. And that anterior projection is actually advantageous to us. How? It is going to prevent the patellar translations. The patella is inserted over here. So it is going to prevent the patellar translations. Right? And now we have other thing, that both condyles are separated posteriorly by the intercondylar notch. This is the intercondylar notch. But posteriorly both condyles are separated. But when it comes together anteriorly, they are joined together. They are joined together by intercondylar groove or patellar sulcus or patellar surface. Here is the patella resting. Okay, so two condyles are clearly seen posteriorly, and when we move from posterior to anterior, both condyles are joined together with the patellar surface or patellar sulcus, or of course known as the femoral groove. Right? So these are some of the peculiarities of the distal end of the femur. Am I going a little bit fast? Let me revise it for you. So the distal end of the femur, right? The distal end of the femur is having medial condyle, lateral condyle. Medial condyle is greater than lateral condyle, right? And then the peculiarities of both the condyles. In the lateral view, both condyles are convex. Right, very good. But the radius of curvature is less posteriorly. Of course, it is evident because this curve is suddenly ending posteriorly. In the inferior view, posterior view, both the condyles are clearly demarkable. You can differentiate between medial and lateral femoral condyles, of course, right? In the anterior view, this is having less convexity, but lateral condyle is projected anteriorly slightly. That is helping in preventing the lateral translation of the patella. The patella is rested over here. So this is actually an advantageous one. In the inferior view, you can see that medial femoral condyle is projecting a bit lower. Right, the medial femoral condyle is projected a bit more down than the lateral femoral condyles, and you have intercondylar groove which separate, intercondylar notch which separate medial and lateral condyle. But when it comes to anterior end, this intercondylar groove joins together. Right, this intercondylar groove joins together to form the patellar sulcus or patellar surface. Right, these are the peculiarities of lower end of the femur. Of course, the other anatomical peculiarities, like you have the adductor tubercle and all those things. This is the popliteal surface, which you have to study in your anatomy sessions. We don't need that in detail in your biomechanics discussion. Now let us move on to the distal end of our discussion on the distal end of the femur is over. Let us move on to the proximal end of tibia. Right? Let us move on to the proximal end of tibia. Right? Proximal end of tibia. This is also quite known to all of us, especially in anatomy sessions you might have studied. This is the tibia, right? This is the tibia, and tibia is having the similarly two condyles, right? Medial femoral tibial condyle and lateral tibial condyle. More correctly, you can call these condyles are plateaus, because this is almost a flattened structure, a plateau like horizontal structure, not like this one. This is not convex. Okay, so the medial and lateral tibial condyle or medial and lateral tibial plateaus. Medial and lateral tibial condyle and medial and lateral tibial plateaus. Of course, the medial femoral condyle is larger, the medial tibial condyle is larger. Because the medial tibial condyle is larger, right? So that is the next peculiarity. The tibia is made up of, proximal end of the tibia is made up of the same two condyles, medial and lateral condyle, right? Medial and lateral condyles, medial condyle and lateral condyle, right? This can be also known as plateaus, okay? Plateaus, okay? Medial and lateral plateau, right? and the medial femoral condyle is larger than the lateral femoral tibial condyle, and the medial tibial condyle is larger, as I told you, but the lateral tibial condyle is projecting slight anteriorly. You can see that the lateral tibial condyles project slight anteriorly than the medial tibial condyle. Of course, you know that the lateral femoral condyle is slightly anterior, so this is also slightly anterior. Now, both these condyles are separated by the structure that is known as the intercondylar tubercle or intercondylar tubercle. See, you have two tubercles, one is in this side and one is in this side. These two tubercles separates both the condyles, and there is a beautiful architecture where this tubercles sits on the intercondylar notch like this. See, the tubercle sits on the intercondylar notch like this. Okay, so there is two condyles and two plateaus, and there is an intercondylar tubercle, right? These are the biomechanical peculiarity. And the medial tibial condyles, you can see that the tibial condyles are relatively flattened, okay, but to the interior, to the center of it, it is slightly convex. You can see that it is to the center of it, it is slightly convex. So the peculiarities of the tibial condyles are they are relatively flat, but to the center of it, the tibial condyles are slightly concave. That is for this condyles which are convex to articulate. But there is one more peculiarity, which is, of course, if you look in the close view only, you can recognize that the tibial condyles are not straight. They are slightly inclined inferiorly, okay, to the posterior direction. It is slightly inclined, about 5 to 7 degrees or 7 to 10 degrees it is inclined. 7 to 10 degrees it is inclined. See this inclination, it is actually helping this convex condyles to rest. This convex condyles to rest on it. So those are the peculiarities of the tibial condyles. There are two condyles. They are relatively flat. To the center it is concave in shape, but to the posterior view, so or posteriorly, it is slightly inclined. See this inclination, this is a straight line, this inclination. Here also you can have a slight inclination, and here you have your meniscus attached, that you will study later. Here you have the meniscus attached. And can you guess the peculiarities of this one? Can you guess a problem? This is convex, this is not completely concave. This convex is resting on a relatively flattened structure, and that is the reason why the tibiofemoral joint or the knee complex is highly incongruent, rather than like the hip complex, that is the femoroacetabular complex, a concave structure, inside that a convex is resting. Not like that, this is congruent, but here this is a convex structure is resting on a flat structure, so that poses a lot of biomechanical problems in the knee complex, and that makes the knee complex relatively less stable compared to the other joints in the human body. That is all about the tibial proximal articular surface. So we have two articular surfaces, the proximal articular surface formed by the distal end of the femur, and distal articular surface formed by the proximal end of the tibia. We discussed in detail and we saw the peculiarities of this articular surface. In next video we will be discussing about genu, valgum and varum and all the biomechanical alteration due to that condition. If you really find this video helpful, please don't forget to subscribe to my channel and don't forget to click the like button.